without further ado, we're going to get started with our speaker. So I'd ask him to come on up here as I introduce to everybody Randy. Randy is at Yniguez. Yniguez. Well, welcome to MOROF. Let's give it up for him. So let me tell you a little bit about Randy in case you didn't get online and read his bio in advance. You can see we're going to be talking about patient-centered medical home today. Randy's an account manager with the University of Central Florida, the Regional Extension Center. And as many have come to know, the Regional Extension Center means a lot here to us at MOROF for assistance in the programming that we provide to our members. He assists healthcare providers to meaningful use, electronic healthcare technology. He's been with the REC since 2011, and he's taken on various roles and duties, including the position of clinical lead and subject matter expert. Randy brings over 15 years of healthcare experience from community mental health, hospital, private sector settings. He's been at the clinical, IT, and managerial levels. In addition, he's an adjunct faculty member for the Department of Health Management and Informatics at UCF's College of Health and Public Affairs. Randy is currently a registered nurse, a licensed mental health counselor here in the state of Florida, and a proud graduate of the University of Central Florida, where he obtained a Master of Science in Healthcare Informatics, a Master of Arts in Clinical Psychology, a Bachelor of Science in Nursing, and a Bachelor of Arts in Psychology. I think we have a pretty smart guy on our hands today. Thank you and welcome to MOROF.
Thank you very much.
Give it up for Randy.
Good morning, everyone. Thank you very much. Thank you for joining us here this morning through the rain and the early morning hours. Thank you very much, Hank. Randy Yniguez. I am an account manager with the UCF Regional Extension Center. Our Regional Extension Center is one of 63 regional extension centers across our nation, developed out of the HITECH Act, which is part of the American Recovery and Reinvestment Act of 2009. Our purpose is to assist our community with the adoption of health information technology, specifically electronic health records in the ambulatory primary care setting, and to assist with the achieving of meaningful use, which is a Centers for Medicaid and Medicare incentive program. And actually, to date, I am proud to say that over $20 million in meaningful use incentive monies has been earned by our provider members at the Regional Extension Center. But today we're going to talk about PCMH, what it is, why it's important, and what providers can do to prepare for the inevitable changes that are on the horizon in our industry. The term PCMH is really more of a strategy that refers to how primary care can be delivered. It's care that centers around the needs of the patients, increase accessibility to care, is continuous, comprehensive, and well coordinated while being culturally sensitive and responsive. So patient-centered medical home, it's not a place, but a model of primary care that maximizes healthcare outcomes. It's centered around, again, it's centered around the patient's needs and fulfilled by a team-based approach that also includes the patient as an essential component of his or her care. It can also be a foundation for an ACO, Accountable Care Organization, and that's another buzzword trending in our industry right now. A little history. Back in the 1960s, the American Academy of Pediatrics developed the concept of the medical home in order to have a centralized medical management system for the pediatric population, especially for those with multiple needs. Then for almost 40 years, there was basically little to no movement on the medical home front, at least not in any significant way. And it wasn't until about the turn of the century that the reports of the high costs, poor quality, poor outcomes, low patient satisfaction, which caused a resurgence in the interest in the medical home model. In 2007, several medical associations formally defined the foundation, the principles of the medical home model, and I'll touch base on those in a minute. And then from 2009 and forward, we started seeing payers and healthcare plans starting to experiment with reimbursement models that fit the patient-centered medical home model. We can talk about that in a bit, but basically the current fee-for-service models that are currently in use in practices across the country, they really can't work with the patient-centered medical home model, at least not solely. When you read the literature on medical homes, you may see various groups and organizations describing what a PCMH is, but in essence, they all build off of the collaborative work of those major groups back in 2007 who formally defined the building blocks of PCMH. They called for the medical practice to offer each patient a personal physician who would lead the healthcare team and coordinate the care of the patient, and they stipulated that this must be done under that the patient-centered medical home must be done under the the direction of a physician. The healthcare team would take a whole person orientation, so it's not going to be just about diagnosing the patient as obese or diabetic, prescribing medications, and then seeing them back in the office 3 months. A thorough understanding and assessment of what's going on with the patient in their lives, what's contributing to their current health status, what this person's cultural and environment, how does that contribute to their health status, and then how can the healthcare team incorporate all that information into the treatment planning for that patient. They called for coordinated care, meaning that referrals are followed up on, the patient is called in between visits, because coordinated care can help reduce the risk of things falling through the cracks. At the same time, the practice takes a vested interest in improving how they deliver their care to the patient. So quantitative and qualitative measurements can provide feedback to the practice, and opportunities for improvement are identified and acted on. Improved access to healthcare has always been a goal. In rural areas, excuse me, it's been a challenge to get the appropriate level of primary care and urgent care. Excuse me. But also in urban areas where people need to see a doctor for non-emergent treatment after hours, but they wind up going to the emergency room for treatment. And then last, the organization that developed the joint principles really recognized that payment reform for primary care services needs to be revamped in order to appropriately reimburse the efforts that go into coordinated care and innovative systems like the medical home model. According to this 2012 report from the Patient-Centered Primary Care Collaborative, which reviewed 46 different PCMH initiatives, there's significant evidence that the medical home model improves the quality of care, population health, and also reduces healthcare costs. Support for the medical home model is ripe, both at the public level and private sectors. And then investment in the medical home also offers both short-term and long-term savings for everyone involved. So if we look at a couple of these statistics here from that report, basically the health plan showed savings based on reduced hospital service utilizations. We can read almost every day articles and reports on the high costs associated with being a hospital patient. And in an age where all we hear about is how costs are spiraling out of control, some ray of hope shines through if changes are made. The quality measures studied by some of the bigger payers showed increases in preventive indicators like screenings, but also in general service categories like women's care, internal medicine, and family and children's health, and that's pretty fantastic. So perhaps as a reflection of the awareness of the effectiveness of patient-centered medical homes, we can see a correlating trend in the adoption of the medical home model. This data is from NCQA, the National Committee for Quality Assurance. We'll talk about them in a couple of minutes, but they have a recognition process based on the number of points that you acquire according to their criteria for what constitutes a medical home. So you can see from 2008 to 2012, we went from just a handful of providers and organizations and practices to thousands of practices and tens of thousands of healthcare providers being recognized as medical home providers. And that's truly outstanding. Where's the support coming from? From multiple levels, from payers and health plans in the private sector to government-backed policies and initiatives at the federal and state levels. And in those comprehensive primary care program states, and Florida is not one of them, the Medicaid pilot programs on PCMH are showing exactly what was hoped to be gained from the medical home model: increased access to care, lowered costs, lowered hospital utilizations, and increased evidence-based practice. So here's another buzzword for you, infographic. This is a nice little infographic on the supporters of the patient-centered medical home, and you can see everyone from the providers and the medical associations to the employers, IBM, FedEx, to the health plans, your Aetnas, your Cignas, United Healthcare, and to the consumer organizations like AARP. So what's been reported in the literature that speaks to the effects of the patient-centered medical home? Is a patient-centered medical home effective? Well, yes. The Medicaid pilot programs alone across the nation have already showed their early data suggesting exactly that it's effective in all these measures here. But several other initiatives, from health plans to health systems, have already documented their findings from their research and experiments, and the results are very promising. So in the end, why become a patient-centered medical home? Our sector of the economy needs change. The triple aim of healthcare addresses those needs highlighted by years of high cost, low quality, poor outcomes, poor patient satisfaction. The medical home model tries to incorporate solutions to all of these. It's actually inherent in its design. So by transforming your practice, you contribute to the larger goals of healthcare reform by using a proven system. Patient-centered medical home, PCMH, aligns well with ACO intentions. That's if your practice is interested in that. Coordinated care, reduction in cost, improving outcomes. Medical homes are at the heart of accountable care organization readiness. And then again, payment reforms are coming. We know this in the industry. The modern medical home is a viable model for transforming from fee-for-service to fee-for-value. And that leads to both long-term savings for, again, everyone involved, from the payers to the patients. If you don't mind, I'm gonna hold off on taking any questions unless there's really something pressing that you need to get off your chest at this point. I'll just move on to the next section here, and then we can field all your questions at the end of it. So there are several types of credentials that an organization can get related to the medical home model. We'll talk about the NCQA recognition because nationally it's the gold standard for the medical home space in terms of credentials. A little background on the NCQA. They're a not-for-profit group up in Washington, D.C. They're dedicated to healthcare quality improvement. They have many initiatives and programs that providers and health plans participate in, including the Diabetes and Heart Stroke Recognition Program, the ACO Accreditation Program, and of course, the PCMH recognition. Who's eligible? Under the NCQA guidelines, the internal medicine internists, family practitioners, pediatricians, and yes, there is actually now a PCMH recognition program for specialists, but it's brand new. We won't get into that discussion this morning, but just know that if you're in these practices, an essential component of quality coordination, making referrals and tracking referrals, that may help drive referrals to those recognized specialists. Because if you're a PCMH recognized practice, would you want to send your patients to specialists who are not NCQA recognized? And the answer is probably not. At the provider level, physicians, nurse practitioners, and physician assistants, as long as the nurse practitioners and the physician assistants manage their own panel of patients. So getting into the NCQA recognition process a little bit, the NCQA process is based on an accumulation of points, and you rack up these points based on meeting criteria outlined by the PCMH program. These criteria are broken down into standards, elements, and then further broken down into factors. All in all, there are 6 standards, there are 28 elements, and 152 factors. Each of the standards contains an item that reflects one of the pillars or foundations of what a medical home is, and these are referred to as must-pass elements. That is, the practice must receive a passing score on these elements in order to get accreditation. If they miss one, then there's no accreditation granted. Here's an example from the NCQA on how a particular element, in this case PCMH Standard 1, Element A, is scored. This particular measure assesses access during office hours, which is an access and continuity related item in the medical home model. You can see that there are 4 factors that make up the must-pass element, those 4 factors being providing same-day appointments, providing timely clinical advice by telephone, providing clinical advice by secure electronic messaging, and documenting the advice in the medical record. And you have to forgive me, but under the yes and no columns, those Fs, those are supposed to be check boxes, but the formatting didn't carry over too nicely. So basically, when a practice is achieving, so for example, a practice does provide same-day appointments. That's factor number 1, and also does factor number 2, providing timely clinical advice by the telephone. Those would be check boxes underneath the yes column, and then factors 3 and 4, if they don't do that, those would be check boxes under the no. And then what you would do is you would go down to that scoring rubric at the bottom, and you would, in this scenario, under 50%, the practice meets 2 factors, including factor 1, providing same-day appointments. And so basically, the practice would get 50% of the allowable points for this particular element, and this particular element, you can get 4 points, if you see up in the right-hand corner. There are 4 points. So they would actually get 2 points. They would meet the criteria for this must-pass element because you only need 50% on your must-pass elements. So they would get 2 points on this element, but for the standard, they would get 2 points out of 20 points, 20 maximum points for the standard. And again, there are 6 standards. There are multiple elements, 28 elements. At a high level, this is basically the process that the practice must go through for NCQA recognition. All 6 standards, all 28 elements, all 152 factors, and then that analysis line by line to see if the practice is performing any of these functions. It's a time-consuming process. It's very detailed. It requires a great deal of transparency on the part of the practice and honesty, but it can be a real eye-opening experience for the practice who doesn't realize that they may or may not be actually providing any of these services. but then it can also be an opportunity for change for that practice. If any of you out there in the audience or any of your clients or partners are engaged in the meaningful use program from CMS right now, there is some good news. You can actually get points towards your NCQA recognition if you have an appropriate system and are using it appropriately. You actually don't have to have an EHR, an electronic health record system, to be recognized as a patient-centered medical home, but having a system, an electronic automated system, can expedite report generation. It can aid in creating efficiencies and communication between team members and providers outside of the practice. And then definitely for higher levels of PCMH recognition, I kind of skipped over that. There's 3 levels of PCMH recognition under the NCQA process. There's level 1, which is the lowest level, and that requires at least 35 points. Level 2, which requires 65 points, and then level 3, which is the highest level of recognition, and that's a minimum of 85 points. At those higher levels of NCQA recognition, you'll definitely need to have an automated system to help you in tracking the data and generating reports. And definitely for compliance with the quality metrics that the health plans and payers and public health initiatives will ask for, it's going to be necessary to use an integrated and complete electronic health record solution. But I just wanted to give you a little idea of where a practice can pick up some points along the PCMH standards and elements with this meaningful use crossover. That's what MU stands for, meaningful use. So, for example, if you look at the little yellow box in the lower left-hand corner, PCMH 3, element E, use electronic prescribing, that's a meaningful use item, and it overlaps with PCMH recognition. So there's a little bit of detail involved, but if you have a provider who's already electronically prescribing and sending it to the pharmacy, those are points that can actually be counted towards PCMH recognition. And actually the 2011 NCQA requirements for PCMH were purposely written to reflect, actually incorporate all of the meaningful use items. So achieving meaningful use on an electronic health record system alone can get you 20.5 points. If you look at the bottom there, 20.5 points, including one of the must-pass elements at 50%. You still don't get recognition for NCQA because you need a minimum of 35 points, but you can see with 20.5 points, you're more than halfway there already for level 1 recognition. So a practice wants to have a gold seal on their wall saying that they are a medical home, or they want to brag to their colleagues and their associates that they are a nationally recognized practice in providing the highest quality care to their patients, or maybe they just want to have some leverage in negotiating their contracts with the health plans. How do they do this? At the Regional Extension Center, our advice is don't worry about accreditation. Don't worry about recognition. Become a medical home first. Do those things that actually are required of a medical home, that actually make you a medical home. Transform your practice from see as many patients as you can per hour to actually spending the time to plan and develop the resources needed to improve patient outcomes. Consider the quality of care that you're currently providing, and then seek to integrate those practices to support change toward an internal culture of performance improvement, a mindset of appropriate and effective care management, and building those relationships beyond the walls of your practice, because patient health care and health outcomes are not solely dependent on what goes on within the exam room. And just the naming convention there, SS1E-A, that's standard 1 element A for the NCQA elements there. The medical home model strives to decrease the disparities in access to healthcare by making things like requesting refills, making appointments, generating or general communication with the healthcare provider more convenient and more respective of the patient's limitations and available resources. So extending clinical hours or partnering with an urgent care center to allow for after-hours care for your patients. Transforming the process of treatment itself to include input from the patient and his family members, or monitoring the patient between visits, and then measuring how satisfied your patients are with those processes and policies. Those are things that practices can start doing now, long before the practice even considers registering or going through the recognition process. In transforming into a patient-centered medical home, it's going to be necessary to become more efficient, more organized, more cohesive as a team in order to implement what's demanded under the medical home model. There's got to be a sound foundation and infrastructure to support the delivery of care that might be vastly different than how the practice is currently running its business. So teamwork, regular staff meetings for operational and clinical issues, revamped job descriptions, leadership from the senior team, and buy-in from staff at all levels. This transformation is really it's a technological disruption to their practice. And then also having the external reimbursement system that compensates fairly for the compensates the practice fairly for their efforts. So we're in the 21st century, right? But almost every sector of our economy leverages computerized and automated technologies, except healthcare. In order to really transform and survive in the current and the future healthcare environment, we need to have our providers on electronic health record systems. These systems need to be certified as to complying to national standards for clinical exchange of data and communication between providers. But the providers actually need to put quality clinical data in their systems for every patient that they see. They need to take advantage of the technology that makes it easier to identify specific patient populations in their practice. They need to use the registries built into these systems to find patients who haven't been into their practice in over a year. They need to take advantage of the clinical decision support systems and alerts that tell them when they're prescribing 2 drugs that might have a deadly interaction for their patients. Then they need to use the data to develop performance metrics for their staff and use the data to actually see if the treatments that they're prescribing are actually helping their patients get better. And we can't do this on paper. So the implications from the pilot programs and studies that the strategy addressing those 4 aspects of primary care will lead to improved outcomes. And that's absolutely wonderful. Will it come to fruition? I hope so. So in order to facilitate the NCQA recognition process, the NCQA came up with a certification. This certification indicates that the individual has in-depth knowledge on the NCQA recognition process. They have their technical experts on the content involved with the standards and the elements and factors. For years, the NCQA was bombarded with requests for referrals to people who actually are familiar with this process. And now there's a list of these certified individuals on the NCQA website. Nationally, there's about 112 of them nationally. There's 10 of them in Florida. 2 of them work at the Regional Extension Center, and you're looking at one of them. So it's a new certification, and they do these certifications, I believe, 3 times a year, and they should be coming out with a new batch of certified individuals. But the Regional Extension Center is currently developing a full service line for PCMH transformation. We see it as a natural extension to the meaningful use work and efforts that we do and what our providers have done in the past 2.5 years. It's going to include an assessment, baseline determination, gap analysis for the NCQA process, education on the process, project management using specialized tools and analytics to track and monitor specifically their progress on the NCQA process. So if you know anyone that's interested in that, please send them our way. We'll be glad to actually give them all the information that they need to get started on that process. I feel like I spoke really fast, and I feel like we have a lot of time left. So, but thank you very much for allowing me to present this information to you. I feel it's very important. I think everyone here in this room is going to be affected by the medical home movement in one aspect or another, either as a patient, as a provider, as a partner to the healthcare organizations that you deal with. I'm passionate about healthcare reform, healthcare change myself, and again, I really appreciate your time. So, if you guys have any questions, I'll be glad to try to answer them right now.
Thank you, Randy. I'm going to be moving around the room. Yep, let's give it up front. Thank you.
Thank you.
Great. I'm going to move around the room and get a little bit of exercise, but please be patient and wait for the microphone to come to you so everybody can hear your question.
Randy, is it necessary to educate the public as to the difference of a practice, which one is certified and which one's not, and what is being done to do that?
Mitchell, thank you very much. I'm of the mindset that it is important to educate the public, because the patients in general, to let them know that there is a difference in the quality of care that can be delivered by their providers. Quite honestly, from what I've seen in the time that I've spent in this, I haven't seen a lot of movement on that end. I think that's where maybe an organization like yours, Mitchell, might be very good to leverage your services in that aspect. Definitely, the patients need to be aware. The patients need to ask their providers, "Are you going to be a medical home? If not, why not?" Thanks.
Good question.
I think a big part of that, to continue on with what, thank you, the chair is going to, with what Mitchell is going to say, I think it's going to be important for the web community, like WebMD and all those search engines on the web, to adopt this and to actually put the certification by the doctor's name. Is there anything being done there? Is there any collaboration?
The NCQA, I believe, and I'll get you the right information on this, but I believe the NCQA, when a provider is recognized as a provider in a medical home, they do have their practice listed on their NCQA website. They do that for the diabetes and heart stroke recognition program, and they'll probably do that for the, they probably already are doing that for the NCQA program as well.
Could you touch a little bit about doctors that are seeing as many patients as they can see versus having the time to visit with a patient in regards to their reimbursables? Right now, if you have one doctor and 5 people supporting him, now he's going to cut back to seeing less patients, more support. How is that going to relate to his profitability as a doctor's office when he's required to have more support and see less people?
Yeah, that's a great question. It's a double-edged sword, right? There's discussions going on right now. Where do the actual cost savings come in? If a doctor has to cut back on his patient load per day from 30 patients to 20 patients in order to deliver quality care, how is he going to make up that revenue? And the hope is that the reimbursement models will make up that differential. Some of the health plans right now are talking about, well, across the country, they're reimbursing higher rates. In Florida, it's still kind of a little bit of a secret what the health plans are actually doing, but the discussions are out there. It's going to be a very tricky, touchy situation for providers who want to be involved with this, but then are apprehensive about the risks involved in terms of decreased revenue. And anytime there's a disruption in their practice, for whatever reason, you're gonna risk that. But those discussions need to continue to happen.
I'll admit to being confused, but at a higher level, thanks to you. And having never served in the military or worked for the government, all these, names and letters and stuff kind of confuse me. Could you just help me grasp the term home and why they chose that semantically? If it's not a place, why that?
I wish I could answer that. It was a concept developed back in the 60s. Yeah, I don't even want to begin to speculate as to why. In my mind, I can see home, more warmth and comforting, more welcoming, but I don't know exactly why the term was used. It is confusing because you think it's a place, and it can actually be a place. There's a Grace Medical Home in downtown Orlando. They're a medical home. They're not NCQA recognized, but they're a physical building, and this is what they do. It sounds to me like it's like a nursing home or something where patients go in and sleep overnight and stuff like that. But I don't know. I don't know why. Sorry.
I just want to thank you for this presentation. I'm a doctor. I am a volunteer physician, but it's interesting that I don't know if this question is tricky or not, but here are the results: 15 fewer hospital admission, 15 fewer hospital inpatient stays. But are the results being evaluated just as the process are implemented? And wouldn't it be nice if we could evaluate both? Because I think that as companies having money and having power, you just go one-way street.
Yeah.
Yet the people that are out there, and I can tell you from my own experience, I chose PUP because I'm not ill. And my God, I didn't know how tough it is. The times I called that I cannot get someone to talk to me like a human being, and this is amazing, And then you need the medicine, and you have to see another doctor because your doctor is working from 9 to 3, and then he's never on call. And then if you're sick, you get to see a hospitalist. And then you have to sit in the emergency room waiting for hours and hours. So I think that I'm not trying to get the head of a critical person, but I think that it would be nice to evaluate also the effect of the actions, because what we do in academia, in teaching, we just see a model of science, and we don't have the human factor. Yeah. And the people that are there experience the results. Maybe one of us or all of us will get in the situation where, we need people to first sit with us and see what's wrong with you, not the computer. Because I like the doctor I selected, but honestly, he was 95% with the computer and 5% with me. I did not care because I'm not sick. And so I'm just saying that would be nice to look at the results. Thank you.
I appreciate your comments. We're just going to we're in the infancy stages of all of these changes. I think we're going to see a lot of frustration, a lot of grief. Again, it's a disruptive process that we're going through right now. I'm hopeful. I'm optimistic that the benefits will outweigh any cons long term. I think there's just going to be some growing pains and some things that we're going to have to go through as an industry, as a nation, to get to where I think we should be. But thank you very much for your comments.
Good morning. This sounds great in terms of having quality versus just quantity, but I'm just sitting back doing the math going, okay, so now there's going to be more people on insurance, and you want the doctors to see less people per. Are there enough doctors to go around to actually do all that?
Yeah, from what I've been reading so far, no, there's going to be a vast shortage of doctors, and that's going to put a lot more strain on the system. You know, I wish I could really speak to a lot more of the politics involved in all this decision making and all these initiatives that are that we're going to be obligated to fulfill, and it's going to be an interesting time for a lot of people, and it's going to be a very stressful time for a lot more people too.
I'm Ken Peach with the Health Council.
Hi.
Question for you. REC covers 8 counties, 10 counties?
7 counties right now.
7 counties, okay. We had a nurse stay with us recently from Boston, and she and her husband had relocated, and in the process of relocating had to find a new primary care home for them, or a primary care group. And in the process of doing that, identified a group. They both are insured. They were under the Massachusetts Health Plan, which of course is the predecessor to where we're moving to. And he's going to get his first annual physical, but it's not an annual physical. It takes him 1 year, 9 months before they can give him a routine physical. So we're seeing an 85% increase in demand, in delays rather, in getting into primary care in Massachusetts. So based on that, based back to this question a little bit, my question is, what are you seeing that's unique in terms of patient-centered medical home? And indeed, is there any movement? For example, I spent a day with a physician from Alaska on Tuesday who's moving into this state with pick up the phone and you can talk to a doctor in 2 minutes. We're talking to another group just a couple of days ago, virtual physician practices. Yesterday, spent time with a physician over in the Newport Richey area who's basically doing a complete mobile approach of coming to people's individual homes. Are you seeing anything unique as that how that relates into the patient-centered medical homes?
You know, I think again, leveraging technologies is going to be key to reforming healthcare, moving on into the future. What's different about the patient-centered medical home is the formalized, structured process that the providers go through in order to create a coordinated care, a true coordinated care environment, so our system isn't as fragmented as it is now. And having standards like the NCQA recognition process doesn't guarantee that you're going to deliver excellent care, but based on the empirical evidence that doing those things that make up the patient-centered medical home will eventually do that and save on cost down the road. Again, it's going to be riddled with speed bumps along the way and potholes, and this is just a work in progress that we're all going to have to do our part to help make it better than what we have now.
Yes, thank you, Randy. I'm Louie with MedBill. Thank you very much for sharing this information. Do you feel like there's just too much pressure in the healthcare community right now with ICD-10 around the corner, meaningful use stage 2, omnibus? Mm-hmm. Do you think that there'll be a similar bust, if you will, of the bubble compared to real estate with healthcare? And according to Mr. Kinpeach, access to care and making appointments and stuff, do you think that might be the way? And do you think that the government is going to standardize the interoperability based out of HIMSS to share New Orleans with the Commonwealth? Do you think that's the key that we're lacking?
Well, definitely there's a lot on the plates of providers and practices right now. Meaningful use and PCMH and whatnot, all these initiatives. In my 15 years in the healthcare field, I've come to realize that healthcare professionals are very resilient. Bounce back, they get stressed out, they yell at nurses, but in the end, you know, we figure out how to cope with the situation. Some of us go along with the situation kicking and screaming, but I can't speak to the what the government plans are in the future right now. It's just not, to me, it's not really clear right now.
Is the Regional Extension Center going to be providing information similar to what they, or services similar to what they did for the meaningful use to providers regarding PCMH? They had a package deal where if you qualified, you got 40 hours of support and that kind of thing. Are they going to be providing the same or similar if there's an interest to PCMH?
We're working out the financial side of that right now. We're actually working with a consulting agency to develop and streamline our process internally. Right now, it looks like it would be a flat rate of some sort, but maybe not a bucket of free hours like we have done with the Meaningful Use project, unless we get on board the partnerships with sponsors, health plans, pharmaceutical industry, and whatnot to create some sort of grant or something that can help us along the way.
I want to say something a little positive about what's going on out there. I will say this. I used to be in the medical field for 5 years, worked for a comprehensive sleep disorder center, and called on 400 doctors' offices. And I had to leave, and now I'm back after 5 years with my dispensary. But what I'm finding out is when I go into these doctors' offices I used to call on, there are a lot of changes, but they've also added some things to podiatry. They've added pediatrics. They've done some things that were, it's kind of, after I saw this today, it's kind of showing that there are some doctors' offices, that one in particular that we just closed. I'm so impressed with what he's doing in his office. He has 50 employees, he has 11 doctors, and what his whole, with us working with him now with the dispensary, everything he's talking about is, Gerry, what else can we bring in that will do help us? What else can we do that with the staffing?
Yeah.
What else can we do with this? And because of all that, I've put some things together with some people that are here to show him that you're kind of going to be like the pilot program, and all the stuff that you're doing and how impressed that we are with what you're doing and working with you, this could be out there. And he's not the only one. I've been out, you know, again with some of the doctors I used to call on. So I will have to say there are some positive things that can help. There are other revenue sources that could maybe offset some of this stuff like we're doing. So I definitely think that there is some positiveness to this out there. So I just wanted to say something like that.
Thank you. Yeah, definitely there's, you know, it all begins with the mindset that that a doctor has and where they want to go with their practice. And the opportunities are there. Sometimes they have to be really weeded out from all the bad stuff going on. But thank you for that. And practices like his should be, you know, marketed and told. His story should be told all over.
At the risk of getting in trouble with Chuck again, I was a part of one of these in California as a part of Kaiser. And it worked really well with Kaiser because they have their own physicians, they have their own network, their own hospitals and everything else. So when you talk about increased reimbursement, to Kaiser that's kind of meaningless. But I'm wondering how the other insurance carriers are looking at this, because if there's an increase in reimbursement for a patient visit, isn't there a corresponding increase in the insurance rate that's going to have to go along with that?
Yeah, and that's a good comment there. What we're hearing right now is in terms of cutting costs for the insurance, for the health plans, they don't care if it's PCMH or whatever you want to call it. If it saves them some money, they'll invest their resources into it. I wish I could speak to the other side. You know, where if you cut costs on one side, where are you going to make that up? Will it come in higher premiums? I don't know. I did read a New York Times article the other day that suggested just that. So we'll have to go. It's not just the obligation or the responsibility of the practice itself. It's going to really take the whole medical healthcare industry, the whole healthcare community to come on board and work through these changes all together and find the solution all together. Because there's too many nuances, too many complexities involved, practicalities of running a practice and providing good care at lower cost. It's just there's not a one solution to that.
Hi, good morning. I've been in the medical field for quite some time. I won't give my years away, but the gray hair kind of gives it away. But anyway, I think when entities create initiatives, I think there's a little piece missing called support. And I think practice managers are working managers as well. Not only are they trying to develop the business side of things and keep the clinical at best practices, but now everybody's spinning so many plates within the practice that it's hard to find those resources and support. So along with the initiatives, I think education to the practice managers, support resources for them to promote the initiatives. So I think when people sit around a table and start brainstorming about how are we going to do this, I think that one little piece needs to be in the concept of how can we support this initiative within the practice. So just a little
I agree.
comment.
Thank you very much. Yeah, definitely agree.
I'm going to our next question, but I'm going to ask one in between. I want to know, Randy, is there an app for that? So when I say that, I'm thinking of all these doctors' offices. I'm thinking of Dick Tracy and how if you wear the right watch, your blood pressure could be taken. You can probably check out your sugar levels or whatever else needs to be done. Is there an app for that? What are they doing in the doctors' offices related to that part of this?
Yeah, not specifically for PCMH, for patient-centered medical home, but definitely there are several electronic health record vendors who have apps where the provider can access the patient's chart or actually do some charting or log calls and encounters on their phone or iPads.
Flip it around. Is there anything on the patient's side for them to be able to retrieve information, to log in information that actually goes back to the EHR system that's helpful to the practice and the patient?
There are some patient portals, patient portal apps. I haven't seen them personally myself. I've just read about them, and but there is that consumer side too. And
does it fit into one of those different segments that you were talking about? If the providers using these types of technologies, does it rate?
Yeah, definitely. Especially if hopefully it's a secure messaging app that would certainly fulfill a couple of the requirements for patient-centered medical home.
And when you say secure, you mean encrypted technology?
Encrypted, yeah, I'm not a security expert, but one where my one-year-old daughter can't access it.
All right, here we go, our next question.
Hi, Randy. I'm
Hi.
Bonnie Stewart. I wanted to ask about the PCMH. It has historically been with primary care providers. I work with ACOs and with practices that are trying to become accountable care organizations. We have a lot more specialists that are looking to take advantage of the ACO model so they can do the Medicare cost savings sharing. And you mentioned that the PCMH accreditation is now moving over towards specialists. The question is because we have like endocrinologists who are seeing that they alone are now in control of that medical home for those diabetes patients, cardiologists, oncologists, who, you know, the shift from the primary care provider is now going to that specialist.
Yeah.
Is that where the model will be? Will the PCMH then move away from the primary care to the specialist in those cases?
There is for specialists like cardiologists or endocrinologists that do a significant portion of primary care services, they can fall under the regular PCMH recognition process. if there's a specialist like an orthopedist, that would fall under the specialized, the PCMH specialty accreditation. But as far as movement down the road, do you mean, towards allowing the specialists to become PCMH certified? They would have to substantiate that their patient base. I think it's 75% of their patients, or not 70. I think it might be 30% of their patient, if they can show proof that they provide like 30%. I'll get you the right numbers, but of primary care to their patient population, then they would be able to get that accreditation.
Right. Any last questions as we're wrapping up this morning? Excuse me.
Good morning, and appreciation for your, this was phenomenal instruction on what's happening in healthcare, but I have a question from the other side, and that is, isn't it counterproductive to the medical loss ratio with regards to the cost of health insurance, which pays for health care, because now the carriers have to pay back for reimbursement, and as they pay back greater for reimbursement, it's going to cost the cost of health insurance to go up, which means more and more people will be out of insurance because it's predominantly employer-sponsored, especially in Florida with under 50 groups, under 50 employee groups.
Yeah, I wish I were qualified to answer that question. It sounds like a similar question to what's been asked before. Where's that, who's going to pay for this in the end? And I haven't really been involved in those discussions. But
raise your hand if you think you're going to be one of those people.
Yeah, I think it's going to be everyone here in the end.
Shared responsibility.
HHS, Office of Insurance Regulation, Department of Labor, and forgot the other acronym, for 2 days on just getting to be able to sell health insurance in Florida and all the requirements that's going to be put on the employers.
Yeah.
This is nothing. This is nothing.
And we're going to close with one last question. Excuse me.
This may be a moot point, but out of 112 that are already accredited, and that's nationally.
Yeah.
Out of the hundreds of thousands or millions of doctors that are out there, is there any sort of time frame that you anticipate that any of this may happen? Or are we going to be, is Obamacare going to be a thing of history by the time something like this comes around?
Right now it's a voluntary accreditation process. The 112 that you're referring to is actually the certified content experts like myself. If you're asking whether or not there's a time frame for all doctors' offices to become patient-centered medical home, I think that's really going to depend on how the bottom line is going to be affected, how their pockets are going to be affected. I don't think so. No.
Well, Randy, we sure feel fortunate to have had you present to us today.
Thank you.
You can certainly tell why he's with the Regional Extension Center. We certainly appreciate their support and what they're doing in the community. We wish you well with all those efforts. And on behalf of MOROF, we've got this nice hot and cold container for you. Thank you very much.
Thank you.
All right, folks, it was good to have you here today.